So it's my pleasure to introduce our Goodnight Lectureship. This is one of our premier endowed and named lectureships, and really here to honor Dr. James Goodnight. Dr. Goodnight began his career at UC Davis now over 40 years ago, has seen the tremendous advancement and growth of UC Davis. He served as the founding director of our cancer center, served as chair for over 12 years before moving on to being assistant dean for clinical affairs and starting the formalization of our practice management committee and board here at UC Davis. His the Goodnight stories are great. In addition to being, a renowned cancer surgeon who used to say that he was really a hand surgeon. He'd like to operate on anything he could get his hands on. He had tremendous specialty expertise that spanned melanoma, breast, and other complex GI cancers. But I think of him not only as a man totally dedicated to cancer, but a man who also loves life, whether that's his choice of music in the OR. For those of you who remember and enjoy heavy metal, there was probably another cohort of people who maybe didn't enjoy heavy metal quite so much. Fast cars and good wine are things that also characterize Dr. Goodnight, who has not missed a beat in his retirement years. I think he's working harder, and he's harder to keep up with than he was here before. I will say that it really has been a privilege to me. He helped tremendously with my transition to coming to be chair here at UC Davis, and we really enjoy and appreciate this particular very special endowed professorship. We're sorry that we can't be doing it in person, but Jim, we're really delighted to have you here, and I'm going to turn over the introduction to our very distinguished virtual visiting professor to Dr. Bold.
It's my pleasure to introduce this year's James Goodnight Lectureship to be given by Sandra Wong. Sandra graduated, she's a Northern California native. Her family still resides in Stockton. She graduated from UC Berkeley with her bachelor's degree, then went to Northwestern for her medical degree. Her residency was completed at the University of Louisville, and then she went to a clinical fellowship in surgical oncology at Memorial Sloan Kettering and ended up serving as the chief administrative fellow. She then moved to Michigan and rose through the academic ranks, honing her skills in health systems research. She finished her career at Michigan as the associate chair of clinical affairs and the William Kuhn professor of surgical oncology before being recruited to Dartmouth to become the chair of surgery at Dartmouth Hitchcock and the Geisel School of Medicine. She also serves as the senior vice president of surgical service line at Dartmouth. Because of her expertise in health systems research, she's been funded by NIH and AHRQ and has a simultaneous appointment as a professor at the Dartmouth Institute for Health Policy and Clinical Practice. She is exceptionally prolific in her writing and has been recognized. She's on the editorial board of 5 journals, including the Annals of Surgery, JACS, and the Annals of Surgical Oncology. Her leadership in American surgical oncology and surgery in general has been well recognized. She just completed her presidency of the Society of University Surgeons. She's the current president of the Society of Surgical Chairs, and she's president-elect, hopefully in 2 weeks, for the Society of Surgical Oncology. She's written quite a bit throughout her career on health systems research throughout the field of surgical oncology, but primarily focused on melanoma, but she's also written extensively about palliative care, health system integration, and really looking at policy and how we can do better with the resources we have. So it's my extreme pleasure to introduce Sandra Wong as our James Goodnight lecturer this year.
Good morning. It is such an honor to join you all this morning, and thank you for hosting me virtually. I want to thank Dr. Bold for that really nice introduction, and to thank you and Dr. Jerkovich and Dr. Farmer for this great invitation. So Dr. Farmer already kind of talked a little bit to you about Dr. Goodnight, and I have to say it's really an honor to give this lecture. And I have to say I've had the fortune of meeting Jim about 15 years ago, and it always struck me that he was such a visionary who always put patients and people first. And that is something really to be proud of, in addition to everything that you've done for UC Davis and everything you've contributed to the field of surgery and to surgical oncology. You know, he knows more about melanoma than just about anyone, and so I'll have to ask his indulgence for any liberties that I might take with this talk. So to put my remarks in context, I wanted to talk about learning health systems. And I was able to join you for your M&M and your CQI conference, which is a great example of what learning health systems are meant to get to. So obviously you can read faster than I can talk, and it's a really comprehensive and complete definition of a learning health system from the Institute of Medicine. But I boil it down to a couple of things. I think it's about capturing and analyzing data. I think it's about continual assessment for outcomes and the ability to use the data and the continuous assessment for learning and improvement. So learning health systems sound really great, right? We're all, you know, trying to get there. I don't think anybody would disagree with the need to continuously learn and improve. I don't think anybody would disagree with the need to continuously improve the quality of our care. So, you know, we can do that a number of different ways. But I think in terms of very specific things to learning health systems, it's really because we have so much medical knowledge these days, and there's an astronomical growth of medical knowledge. And as many of you know, there's a huge gap between the acquisition of this knowledge, the publication of this knowledge, the dissemination of this knowledge, the actual application of this knowledge to improve care at the practice level is really slow. And I think that learning health systems will help us get to a faster pace of implementing the care that we know that we should be rendering and the care that we know our patients should be getting. And we're really helped by the advent of technology and data analytics. In your CQI conference, you showed a lot of data. A lot of it was generated pretty automatically and on a routine basis, not necessarily at the touch of a button, but you know, much different than just 10 years ago when getting data was much more of a slug. And I really enjoyed hearing about some of your interdisciplinary processes that you use in order to affect the change. And I really think it speaks a lot to your culture because your culture supports this continuous feedback, and in many ways doing it on a regular basis, calling out your successes, thinking about work that still needs to get done is a huge part of learning health system. And in many ways, the system is a cycle. And I think that in many ways, that's the beauty of learning health system, right? It's the cycle. So what I'm showing here is one of the original kind of conceptual models, if you will, which really emphasizes the cycle. And this cycle actually starts at the 6 o'clock area. So the blue colored arrow is really kind of the afferent limb, if you will. So it gets you to assemble the data, again, made much more easy with our current data systems. It gives us the ability to take that data and analyze it. And I'll specifically call out what two of the things that I noticed that you did in your CQI conference. And that's internal analysis, which is sharing the data amongst yourselves, talking about it, but also benchmarking it to external data. And using Vizient or using NISQIP is a really great way of doing that. And putting those things together, you get to the interpretation cycle. This is the teams. These are the conferences. These are the root cause analysis things that we do, and really this is all about systems that you have in place for continuous quality improvement. Now the red arrow is really kind of the efferent limb, if you will, and that gets to, after you've assembled, analyzed, and interpreted the data, how do you get the data out there? How do you feed the data to people in order to effect change? And I think that this is where a lot of the action takes place. And while the blue limb is really about data analytics and technology, the red limb is really about people and relationships. We know change is hard. On the afferent side, I will say there's a lot of disruptive innovations that make this cycle potentially a lot faster than what we've currently experienced it as. And not only do we have the ability to get data more quickly, we're actually much more nimble with data. And disruptive innovations like big data and machine learning, as well as artificial intelligence, will only help us move data through faster, more effectively, and possibly in a more user-friendly fashion. Now, on the efferent limb, I think there's a couple of facilitators. There was a question during the presentation with your CQI about the impact of hospital-acquired infections and other things on CMS policy and payment. And so a lot of those things will get people to pay attention that change may in fact come faster because of that. And as we're all living through a public health emergency or a pandemic, a crisis situation, if you will, really hastens the pace of change. I think that looking at it now, over a year in, we've done a lot in this year. Some of it's been frustrating, no doubt, but I will say that crisis situations really accelerate change. It really accelerates our ability to accept change and recognize how resilient our health systems really are and really need to be. So I use this as a basis, I think, because I'm going to talk a little bit about history and historical data. And there are a lot of aphorisms about history, and I think this one's as good as any. And this is straight from Shakespeare, and what's broadly taken away from this part from The Tempest is what's past is prologue. And interestingly, the picture that I'm showing here is a statue outside of the National Archives building in Washington, D.C., and the sculpture is aptly named The Future. And what you see down kind of at the pedestal upon which the sculpture sits is the saying, what is past is prologue. Now, I will say that this gets interpreted kind of two main ways. The first is a little bit more of a cynical interpretation, if you will, and that's that history is doomed to repeat itself. And I will say that as physicians, I think we spend a lot of our time, I think we spend a lot of our day trying to make sure that natural history is something that we might be able to alter. So I do think that a more optimistic, slightly more optimistic interpretation of what's past as prologue is that the past actually prepares us for future opportunities. And while these aren't entirely separate concepts, I do think that learning from data is really our way of taking history and making it apply to the future. So, when we talk about learning health systems, I think a lot of it means that we're applying it to the health system writ large. How do these systems impact our hospitals, our health systems, our departments, our services? But I think on a microsystem level, I think we can apply this to how we change the course of disease. And as a surgical oncologist, I think there's a lot of examples of this. I think we've learned a lot and have come a long way with cancer screening. We've done cancer operations better. The mortality rate and the morbidity rate from cancer operations has declined a lot if you take a long view on things. Certainly, we've benefited a lot from the advances in systemic therapy. And I think overall in surgery, we just have much better pathways of care. I know earlier this morning you showed some of your trauma pathways, and congratulations on all that work. It really does make a difference from not having trauma systems at all. I think these pathways of care also apply broadly to many things like bariatric surgery and to pathways that we have for, say, emergency care. I will say that there are also better pathways of care writ large that make our life better. So as much as many of us complain about the electronic health system, we'll say that gone are the days where you have to go to the film room to retrieve the single copy of the CT scan and lugging around of your paper charts. So I will say that if you take the long view on things, that we really have done a lot of things to change the course of disease. And the learning health system can, in fact, be applied to specific disease processes. So I'm here today to talk about melanoma and specifically about regional disease in melanoma. And so I'll submit to you that history informs our current state, and I think that looking at history may help us for considerations of future care in melanoma. So really, no history talk, if you will, is complete without sort of going really far back and defining what it is that I hope to address. So the discovery of melanoma really dates really far back to 5th century BC. And it was, kind of described as a black cancer, which was really unconfirmed for many, many centuries. But throughout that time, there were a lot of descriptions of fatal black tumors with metastases and black fluid throughout the body. And really, that was kind of the earliest descriptions of melanoma. Now, given how hard it is to preserve skin and soft tissue, it shouldn't come as any surprise to you that archeological evidence really came in the form of metastatic disease, and specifically of bony metastases. And radiocarbon dating actually shows the earliest findings to be over 2,400 years old. But the first resection of melanoma really kind of dates to 1787. John Hunter, really a very well-known name in surgical history, a Scottish surgeon, was thought to have resected a cancerous lesion from the jaw of a 35-year-old man, which was described as soft and black. And remarkably, that tumor is currently displayed at the Hunterian Museum in London. And, while he's credited with the first resection, it was pretty unclear that he knew he was dealing with melanoma at the time. But in the 60s, somebody went back and actually took that tumor and histologically confirmed that it was melanoma that he had resected. But in terms of claiming credit for it, I will say it was sort of a fist fight between two people. Dupuytren kind of claimed it, but to this day, it's pretty unclear if it was melanosis that he was describing. And this is the same Dupuytren of Dupuytren's contracture. On the opposing side was Linnaeus, who described it and wrote about it. And he's a chest surgeon, actually the person who developed the prototype stethoscope. And as a chest surgeon, he noted some deposits in lungs that seemed to be quite different from tuberculosis, which was really kind of the reigning disease of the day. And he really described it as quite different than TB. He described it as different than carbon particles that people were inhaling during that time. And he used the term melanosis as well, but he actually went on to describe the same type of disease process in multiple areas of the body. But in terms of who got it kind of down and called it melanoma, it was William Norris. And he was credited with the first really thorough case report of melanoma in 1820. In this case report, he described a 59-year-old man who he had personally followed over the course of 3 years, including an autopsy that he did himself. And what he described was that there was always a mole, and that when the mole was removed by a knife, it seemed to kind of recur very quickly. And then he went on to describe what really we now know to be regional nodal disease, was that the glands of the groin were swollen. And on the autopsy that he did, he found deposits in the subcutaneous tissues, in the GI tract, and in many, many other areas of the body. And he described a lot of these findings to be shockingly morbid. So a pretty thorough, I would say, case report, since it included an autopsy. And he actually went on to report the first case series of melanoma. I think he became pretty obsessed with this disease process. To his credit, he described a potential genetic association because he described a father and son case. He described the natural history, including the local recurrence, nodal metastases, satellite tumors, and then widespread dissemination. Interestingly, he was very observant about how a minimal excision, basically an incomplete resection, led to recurrences. And he made the noteworthy observation that surgical treatment was really not effective when the disease was disseminated. So not operating on metastatic disease, so to speak. So a little bit later down the line, there was the first report of an excision of lymph node metastases that was actually reported in the Lancet. And this was a 45-year-old woman who had a very, very enlarged tumor that was presumably a lymph node that, when cut into, demonstrated darkened lesions and pigment characteristic of melanosis. So really, all of this set the stage for Herbert Snow to become the original champion of the elective lymph node dissection. He took all of these data and kind of put together what he described as anticipatory gland excisions, noting that when melanoma was seen of the skin, that regional lymph node disease was soon to follow. And so he really thought it was very essential not only to resect the skin lesion, but to also remove what were described as the lymph glands, which first received the infective protoplasm. And he noted that doing it kind of preemptively or earlier seemed to make a big difference. So in many ways, he really set the stage for regional nodal management in melanoma. Handley actually was the one who kind of perpetrated a lot of the natural history, if you will. And he reported an autopsy finding of melanoma that spread from the skin through the subcutaneous fat to the fascia to the muscle, and what he described as lymphatic permeation. And so based on these autopsy findings, he really formalized recommendations for a wide excision and a regional lymph node dissection, much as Snow had been doing for many, many years leading up to this. And a gentleman by the name of Pringle actually advocated for resection of a strip of skin between where the lesion started and the lymph node basin, thinking that you could strip the lymphatics and that might make a difference. That was pretty short-lived, but I think just speaks to how people were thinking about lymphatic spread of disease. So in this schematic, you can see the timeline along the x-axis, if you will, and then kind of what I conceptualize as radical resection at the top of the y-axis, and then kind of more expectant management or less than radical resection for all at the other end of that y-axis. So you can see the major players there being Snow and Handley. And many of you are probably already hearing parallels to Halsted. And in many ways, Halsted's work was really based in part on Handley's beliefs and the things that Handley demonstrated with his studies. And his radical mastectomy was actually described 2 years after Snow described doing radical lymph node dissection. And I would say that surgeons of this era really did not believe that cancer spread via the bloodstream, and therefore were huge proponents of local regional treatment. And this saying is very Halstedian, if you will. Disability, ever so great, is a matter of very little importance as compared with the life of the patient. Again, feeding that notion of requiring very aggressive local regional treatment. So, I think that if you kind of just look at the timeline here, it was really about getting past getting all the cancer, if you will, at all costs, to really considering the morbidity of doing potentially unnecessary surgery. So, but for 50 years, I would say, pretty fairly 50 years, elective lymph node dissections continued until there was a better understanding of histopathological features of melanoma and prognostic values of that. And this is credited to Alexander Breslow, an American pathologist, and the person for whom Breslow thickness is what we use to grade or stage melanoma, if you will. So Breslow did a small case series where he actually crisply showed that thickness of the melanoma was the most prognostic parameter, and that all patients with a thickness of less than 0.7 seemed to survive, and that the incidence of metastatic disease was actually proportional to how thick the tumors were. So this was a game changer. And I would say that on the basis of Breslow's work, questions were being asked. The first question was, where is the disease? And secondly, what's the risk of disease? And that tips into the thinking that maybe not everybody needed a radical lymph node dissection. So let's talk about lymphatic mapping. And that gets to the question of where's the disease. I would say that the historical version was based on Sappy's atlas. You can see that using mercury injections, there appeared to be this totally predictable pattern of drainage. Look at these beautiful drawings that basically had a strict midline division and a strict division right at the waistline, or right at the umbilicus, if you will. Really leading to the belief that there was completely predictable patterns of drainage. Now, we all know that that's really not true. But it really wasn't until much later, with the advent of radioactive colloid and lymphoscintigraphy, that it was actually demonstrated that these absolute rules about lymphatic drainage were disproven. And, a series of really elegant studies demonstrated that. But kind of in the 70s, 80s, and early 90s, I would say that it really was demonstrated that the concept of the midline and the umbilicus being these like hard and fast borders, if you will, were gone. And so you can see that for drainage to the right axilla, there are a lot of different areas of the skin that actually pertain to right axillary drainage. And you can see some of the mapping studies on the right-hand side of your screen that actually demonstrate that you can inject at multiple sites and see drainage to both groin and axilla, and oftentimes in a surprising fashion. So that actually demonstrated that really aggressive local regional surgery may have been misplaced because you might not be getting the basin at risk. And then there was the gnawing question about what was the actual risk of disease. And really the thought that maybe not everyone needed a lymph node dissection. Remember, Alexander Breslow basically said if you had a really thin melanoma, your survival was nearly 100%. And then it came up to a question of that timing may not actually make a difference. When you actually did that lymph node dissection may not actually make a difference. And let me define some terms here so we can look at the really landmark and seminal studies that were done to examine this. So an elective lymph node dissection basically translates to an immediate lymph node dissection, so done at the time of the wide excision of the skin lesion. And therapeutic lymph node dissection really translated to a delayed lymph node dissection, that you did the lymph node dissection when there was notable palpable disease. So really this was a big change in how regional nodal disease and melanoma was viewed, and that timing may not actually make a difference, that getting it preemptively versus getting it when you could feel it may not actually change disease course. So a series of randomized controlled trials were done, and this one is the WHO Melanoma Group Trial number 1. And this actually randomized patients to either the immediate lymph node dissection versus a delayed lymph node dissection if and when lymph nodes were noted to be involved. There were over 500 patients in 17 centers internationally, and these really only included upper and lower extremity lesions only, largely because you could much better predict which lymph node basins were at risk. Now, I actually can't remember which line is which, but it actually doesn't matter because these lines completely overlap, indicating that there really was no difference in survival based on elective lymph node dissection versus therapeutic arm. Following this, another WHO trial, this was termed number 14, was performed, and this really focused on truncal lesions. And this schematic, largely based on previous descriptions of how lymphatic drainage patterns were felt to be, determined how patients were randomized and what nodal basins were dissected. Later in the study, based on findings with lymphoscintigraphy, there was some attempt at lymphoscintigraphy, but most of the patients in this trial actually just had the basins as indicated on this drawing dissected. Nevertheless, here are the results. And you can see here that, and this is the final report on this, which means that there was actually quite long-term follow-up. And you can see here that this particular study really only included thickness of greater than 1.5, whereas in the previous trial, it was all comers. And so here you see that there is a little bit of splaying of the curves, but really, in terms of statistical significance, there really wasn't any at 5 years. In the delayed group, it is notable that a certain number of patients were in that group, and that oftentimes those recurrences were found within the first year. And there was a little finding that I think was a little unexpected at the time, was that a lot of these patients, when they did come back with their palpable nodal disease, that they actually had synchronous metastatic disease, meaning pretty advanced disease. So again, a little bit of splaying in the curves, which made a lot of people pretty excited, but at the end of the day, no conclusion could be made that there were any differences between immediate and delayed lymph node dissection. So the third kind of major randomized clinical trial that was done was the Intergroup trial. And again, same randomization schema. This particular trial really only focused on intermediate thickness melanoma. So WHO number 1 was all comers. Number 14 was really kind of greater than 1.5 millimeters. And here it was really focused on the intermediate thickness. So excluding those patients with very thick melanoma, thinking that they were at such high risk of metastatic disease. So international trial, and this shows the survival curves from the final report, which indicates very long-term follow-up, 10 years, demonstrating no statistical significance in terms of comparing the elective lymph node dissection group to the therapeutic lymph node dissection group. So you can see here that there was a lot of shift in terms of thinking, right, from the top of the slide, if you will, to really radical lymph node dissection right at the time of wide excision of the skin lesion, to really kind of watch and wait as a strategy, and that was the observation arm. And so really a big shift in thinking from radical resection for all to expectant management. And as these data were coming in and with longer term follow-up, there were opportunities to really do a meta-analysis. And so this meta-analysis was done, very long-term follow-up. You can see the results here, confirmatory of everything that was seen in the randomized controlled trials. And the pooled odds ratio for overall mortality was 0.86, but again, with pretty wide confidence interval and ultimately no demonstration of any difference between the two arms. So that was kind of where the state of the science was. And in fact, people were moving away from the concept of radical lymph node dissection at the time of surgery. And I will say that here's the history part, right? It gives you an opportunity to kind of look at the trials. It gives you an opportunity to overlay clinical practice with what we found in clinical trials and really think about scratching deeper than the surface of the bottom line in terms of the conclusions of the clinical trial. And along the way, pretty consistently through all of these trials, it was noted that patients undergoing the elective lymph node dissection, about 20% of them had positive nodes. And so in about 80% of patients, again, pretty consistently across all the groups, these lymph node dissections were being done for negative disease, so essentially removing negative or normal lymph nodes. And there was a thought, as you can see from the enrollment criteria across all of those randomized controlled trials, that some of those patients who were waiting actually had an unrecognized systemic disease at the time that they were undergoing their lymph node dissection. So maybe the timing wasn't quite right. Maybe there was something to be said for removing the disease when you could get to it without having the metastatic disease. And so again, it was sort of a question of timing. And were there better and earlier ways to select which clinically node-negative patients would have benefited from the node dissection, understanding that all comers, about 20%, had involved nodes. And so here's where subgroup analyses come in. And subgroup analyses are oftentimes very, very criticized for randomized controlled trials. But I think as we get better with data management, I think as we get better with analytics, there sometimes is a role for these subgroup analyses, and certainly it sets the stage for further studies. So in this subgroup analysis from the Intergroup trial, and remember this was the one that included the intermediate thickness melanoma, it was actually seen that there was a difference in survival between non-ulcerated tumors, patients with non-ulcerated tumors, and patients with ulcerated tumors. And you can see that there's a frame shift of those survival curves. Now, if you're comparing within the groups, you can, again, see no difference in the ulcerated tumors, right? That p-value is 0.61 between the elective arm and the delayed arm. But in that non-ulcerated group, again, subgroup analysis, but the result is statistically significant. Actually seeing that there might be a benefit to an early or upfront lymph node dissection compared to a delayed lymph node dissection for those selected patients with non-ulcerated tumors. So maybe those with a better prognosis overall benefited from more surgery. And you can see here that that same possible survival benefit for an early or elective lymph node dissection was seen in patients with relatively thin lesions, those with 1 to 2 millimeter thickness lesions. And you can see here again that in this group, these curves do look different, and the results were statistically significant. Again, subgroup analysis, so people really didn't know what to do with these. And at the time, subgroup analyses were very much criticized. But again, opened up the question for what patient selection factors could be taken into account. So subgroup analyses were also done for the WHO 14 trial. And let me walk you through this a little bit because I think the curves are a little bit confusing. And so stratification was by node status and by timing of the lymph node dissection. So essentially what you see here in the dashed lines are those patients that underwent elective lymph node dissection. And in the solid lines were those who underwent the therapeutic lymph node dissection. So you can see here when you compare those essentially negative nodes, you can see here that timing really wasn't an issue. Delayed versus immediate. If the nodes were negative, they were negative, and there was really no difference in survival. I know that sounds not shocking, but at the time, there was a lot of kind of interest in this finding, if you will. Now, if you look at the bottom two curves, you'll see the N0 positive and the N1. So essentially what this represents are those patients who developed delayed disease and underwent resection, and that's the N0 positive. And then those patients who had an immediate lymph node dissection with actually pretty bulky disease, so the N1 lesion. And you can see here that the results are quite different, statistically significant. And what you could potentially infer, and what a lot of people inferred from the N0 positive line, if you will, is that timing may make a difference if the nodes are positive. And what if you would have taken out those nodes when they were less involved, meaning micrometastatic disease? And so it really got a lot of people to thinking and really portended the next wave in thinking about regional lymph node disease. And it really starts to make you think about selection and patient selection and how selection may actually be the key here. So just want to focus a bit on the work of Don Morton. And many of you may know that Dr. Goodnight and Dr. Morton were actually colleagues and did a lot of much of the early immunotherapy work back then. So if you're interested, you can look at those papers. The topic of this talk wasn't immunotherapy, but really kind of lends itself to thinking about how a few people really influenced the shape of melanoma and how we take care of melanoma today. And it was Dr. Morton who really introduced the concept of sentinel lymph node biopsy via mapping. And, he pioneered these studies. He did them in cats, he did them in humans, and really used blue dye first and foremost. And really, the key here was really the exacting pathology review that was necessary for these lymph nodes that were taken out early in the era of sentinel node biopsy. So really, the first reports from Dr. Morton described the technical details of sentinel lymph node biopsy. The identification rate was reasonable, not as good as it is today, but nearly 82% with the blue dye injection. And really, not surprisingly, about 21% of these nodes were positive. And that 20-ish percentage proportion was seen previously. And about 12% of those were seen with H&E only. So, I would say a proxy for slightly bulkier disease. And there was a 1% false negative rate. So the mapping technique was actually felt to be very, very accurate. And this whole concept of sentinel lymph node biopsy or selective lymphadenectomy really was refined in breast and melanoma in the late 90s and early 2000s. And, I was a resident at Louisville at the time when Kelly Masters was doing the University of Louisville breast cancer study, looking at sentinel lymph node biopsy in breast cancer, and the Sunbelt melanoma trial, looking at sentinel lymph node biopsy in melanoma. And I was so lucky to be a part of that early research, and so I guess you could say sentinel node biopsy's been kind of a part of my thinking for a really long time. And so along this timeline, you can see the contributions that Dr. Morton made to really being able to do much more along the lines of expectant management in the setting of being able to select patients via sentinel lymph node biopsy. So multiple iterations of MSLT1 have been reported. Very briefly, I know many of you are familiar with this. It was a randomized controlled trial, international accrual, that basically randomized patients to wide excision with observation and a lymph node dissection if there was relapse of disease, compared to wide excision with sentinel lymph node biopsy, followed by a completion node dissection if the node was positive. This final report, published in 2014, was 20 years in the making, from the time of first accrual to the time of this report, because every patient in the final report had 10 years of follow-up. MSLT2 was viewed as a negative trial. The primary endpoint, as the trial was written, was around melanoma-specific survival with sentinel lymph node biopsy, and the results were not statistically significant. I will say, however, that there were several important takeaways, and possibly more important than the primary endpoint itself. We learned that sentinel lymph node biopsy has important prognostic value. It tells us whether or not a patient has an involved node or not, and really influences staging for patients. I will say that the secondary endpoint was pretty important and was found to be significant, and that was improvement in disease-free survival. So I'll show you very briefly here the survival curves for the intermediate thickness melanomas on the left side of the screen and the thick melanoma on the right side of the screen. And you can see for the secondary endpoint, disease-free survival, that the results were significant. And this is largely because after a positive sentinel lymph node biopsy, a completion node dissection was done, and likely prevented a lot of the lesional recurrence that was seen in that observation arm, remembering those patients got wide excision only. And I will say that some of the other major findings from MSLT1 really emphasized that early completion lymph node dissection, guided by the sentinel lymph node biopsy, had some other benefits. The extent of nosal involvement at the time of surgery seemed to be a lot less, so that really just speaks to the natural history of disease. And then the rates of surgical complications compared to later lymph node dissection was real, and again, probably related to the extent of nodal involvement. So based on those findings and evolving findings, working with ASCO and the SSO, we put together kind of the first set of guidelines around sentinel lymph node biopsy in melanoma. And the recommendations mirrored that of the randomized controlled trial, MSLT1, which is that a completion lymph node dissection should be done if the sentinel lymph node biopsy was positive. These are outdated now because of the way people were practicing and because of another randomized controlled trial, which was on the heels of MSLT1. And that was really because people started asking the question, do we really need to do the completion lymph node dissection? And I will say that even without a lot of evidence, practice was already changing. We did this trial back when I was a fellow, and we essentially asked people to submit their data. And what we did was we looked at those patients who were sort of either choosing themselves or having their surgeons choose not to follow a positive sentinel lymph node biopsy with a completion node dissection. And you can see here that there is some signal in the survival curves and how they split, and that the proportion of patients free of nodal recurrence seemed to be potentially a little bit different. However, in terms of survival, those curves almost overlap. And maybe it's not a fair comparison, retrospective study, a lot of selection bias, but I think it really gave a signal, and I think that this presented enough equipoise to really help with the accrual to MSLT2. We also saw that people out in the community and at academic medical centers who were practicing actually only were doing completion node dissections about 50% of the time. Study after study demonstrated this. NCDB data demonstrated this, and this continued throughout the entire period of enrollment to MSLT2, which I'll tell you about in a second. But I actually think it made enrollment to this randomized controlled trial kind of difficult. When you have people who are already practicing ahead of the evidence, it makes it hard to go back and put patients into a trial, especially where the randomization determines what happens to the patient. So MSLT2 is shown on the right-hand side of the screen. A trial, very similar trial that was done in Germany called the DCOG trial is shown on the left-hand side of your screen. Those results look really, really similar. And essentially, MSLT2 and DCOG randomized patients with a positive sentinel lymph node biopsy to completion node dissection and observation. The observation arm included pretty strict follow-up, including regular ultrasound examinations to really pick up disease if it were to recur earlier. So, we put these results together in many ways just to help people interpret it. You can see here this kind of side-by-side comparison. The results are strikingly similar. No difference in melanoma-specific survival, no difference in distant metastasis-free survival. The DCOG group actually looked at overall survival, no difference. So you can see here, this trial really affirmed what many people were already doing in practice, which was not to follow a positive sentinel node biopsy with a completion node dissection. The groups were pretty similar in terms of the extent of disease in the lymph nodes for the patients enrolled. There was some slight difference in the positivity rates of the non-sentinel nodes, but probably speaks a little bit to patient enrollment criteria, since it was extraordinarily difficult to enroll to MSLT2 for many years. And you can see here that it really does appear that the nodal basin control rate was real and probably reflective of those patients who were found to have additional non-sentinel node disease on the completion node dissection. We followed this with a meta-analysis. We took cohort studies that weren't reflective of randomized controlled data. These were retrospective data. We combined them with the randomized controlled trial data, and you can see here absolutely no difference in mortality between completion node dissection versus the observation. So based on all of those findings, based on the need to really kind of put something out there, if you will, we pulled all the data again, used all of the data that I just showed you, and revised the guidelines. So we fought for weeks over this wording, and we came up with either completion lymph node dissection or careful observation may be offered to patients with low-risk micrometastatic disease with due consideration of clinical pathological factors. I will say that this is very carefully worded, but in practice, it's really that careful observation is being offered and being done, and really for all comers. So, you know, along this timeline, I will say that practice has changed a lot, and you can see that over the course of time, we've moved from radical resection to expectant management for nearly all patients, understanding that sentinel lymph node biopsy is really a great way to stage patients to actually determine which patients go into which bucket, if you will. I do think that it's important to note, looking into the future, the timeline being 2021 and beyond, that we now have very, very effective systemic therapies, and these therapies are being applied in the adjuvant setting. So sentinel lymph node biopsy is essential. It is also important to note that almost all of these adjuvant trials, at least those reported to date, included patients who did undergo the completion node dissection. So I think that some of these data will evolve, though I don't think it'll change the outcome very much at all. Understanding that of a pretty small proportion of those patients that undergo completion lymph node dissection have additional nodal disease. In the operating room, it does make us a lot more circumspect about making sure we get all of the disease at the time of the sentinel lymph node biopsy. So really being diligent to technique during the time of that sentinel node biopsy. And, you know, there's really not enough time to cover neoadjuvant therapy, but I think there'll be evolving data on that. On the subject of neoadjuvant therapy, I think I'd be remiss not to state that that we really need to remember that sentinel node biopsy and all the data wrapped around sentinel lymph node biopsy is really for those who present with clinically occult disease. If a patient walks in with palpable nodal disease, anything that we're seeing from the sentinel lymph node biopsy data is really, I would say, null and void. I think patients who walk in with kind of palpable disease have a different disease biology. And that's probably where the question of neoadjuvant therapy comes in, not for patients necessarily with micrometastatic disease. And I will say, and I won't spend too much time on this because it's a talk in and of itself, but I will say that there's still a role for primary tumor characteristics in terms of overall prognosis and treatment of patients. So on the left-hand side of the screen, you really see stage 1 and stage 2 patients and the survival curves, and then on the right side of the screen, you see stage 3. You have to note that the y-axes are different, so you can't really superimpose these curves, all right? The y-axis on the left-hand side is really blown up, if you will. But you will note that for the patients with kind of 2C disease, that they oftentimes have a worse prognosis than your patients with the 3A disease. So it's important to remember that sometimes having a positive node doesn't, even though it stages you differently, doesn't necessarily portend a terrible prognosis. Many patients with stage 3A disease actually do quite well without additional treatment. And sometimes when you have a negative sentinel node result, like in the 2C with a very thick or high-risk primary tumor, that all of those things still need to be considered as we take care of the patient going forward. And so because of those findings, I think there's so much interest in molecular classification and prediction. So I'll just take this opportunity to opine a little bit. I do think that this will be the future. I don't think we're quite there yet. So in other words, I don't think molecular classification beyond what we currently have is ready for prime time. We know that melanoma tends to be quite challenging in terms of how heterogeneous the tumors are. They tend to have a high frequency of acquired mutations and therefore are considered event-rich cohorts in terms of molecular classification. These classifications do seem to be distinct in prognostic, but they don't seem to be any better than our current data, which mashes up Breslow depth in sentinel lymph node status. And we actually have pretty good multivariable models and nomograms that are reflected in kind of current day AJCC staging. So while we continue to advance the forefront of molecular disease classifications with precision medicine, I just don't think it's quite there in terms of usurping what we currently have in place for melanoma. But I'm hopeful that we'll get there. I know that there will be a lot of data coming forward on that in the coming years, and that'll be really exciting, much as immunotherapy and targeted molecular therapies has been. So I will say that in terms of our learning health system from melanoma, that history is actually really important in this, and that if we look back on some of the data and pool it together with some current data, that I actually think we'll learn a lot. And I think that we will continue to learn that less may be more. And I think importantly for this surgical audience that we need to remember that less is more is not necessarily a minimalist approach, if you will. I think sometimes being conservative, if you will, is the new and radical thing to do in surgery, and a shift of a mindset for us, to be sure. And the oncologist in me will tell you that I think the more part of it will come in the form of non-surgical advances. So as we get better with molecular technologies and as we get better with systemic treatments, especially immunotherapies, we will see a lot better treatment for melanoma patients coming forward. So that's what I have for you this morning. Thank you very much for your attention, and thank you so much for the honor and the privilege of giving the Goodnight lecture. I don't know if we have any time for questions or not, but I'm happy to take them.
Well, Sandra, I really want to thank you for that great overview and history of melanoma, and I want to take the last minute to invite Dr. Goodnight to the podium here. I'm going to make you walk up to the front so we can highlight you. Manny will have you do your magic back there and make a comment and ask our time for our one important question.
Well, Dr. Wong, thank you. What an unbelievable history presentation. I mean, the memories flooded in as you went through the trials and so forth. I think every surgeon, certainly every surgical oncologist, absolutely wants to do the best for their patient. And you're faced with, well, if I do less, am I consigning my patient to death by metastatic disease? The critical nature of doing clinical trials, I mean, surgeons are famous for saying, well, in my experience, which meant they had one case, or commonly occurs they had two cases, and if they said, well, case after case, that meant they had three cases. And so Dr. Wong and colleagues have spent her career basically looking very carefully at broadening that experience to clinical trials, well-done clinical trials, which even are hazardous, as she's presented and so forth. So striving to just get better and better data, better and better experience, which then one takes to the treatment of the patient, as she so nicely demonstrated. We tried very hard to recruit Dr. Wong right after her surgical oncology fellowship to UC Davis. We put on all the stops and tricks and dastardly deeds and so on and so forth. But her career demonstrates why we were so desperate to recruit her. And so congratulations with everything you've done, Sandra. And what an honor to have you here. And I think you nicely demonstrate where next. All along, I think everyone in the field said what we need in the treatment of melanoma is a decent systemic agent mimicking breast cancer. And happily now, after years of my own cynicism, immunotherapy is showing promise in the disease. So I think you've paved the way for what will be essential clinical trials and what will be a useful systemic impact, and even to the point of potentially eliminating surgery. You also gave air to the fact of the vagaries of the disease, what a strange biology melanoma is, from tiny lesions that produce big nodal disease to massive primary lesions that don't show any node metastases. Then how does that relate to the ultimate finding of systemic metastases? The one thing for sure is, this is not something you want. And so, like so many things. Anyway, Dr. Wong, we can't thank you enough for presenting this lecture, and Dr. Farmer, Dr. Bold, and all of this department, which in normal times absolutely fills this room, is so heartwarming to me. I mean, to see that the very bright, very talented people that come after you build and validate the things that you've done. So thank you all. And again, Dr. Wong, thanks so much for joining us. Actually, now that we can do you on Zoom, we may just invite you in often. So thanks so much. Thank you all.
I would love that. Thank you all so much.
Thank you again. And Sandra, as I said at our sort of Zoom dinner the other night, you've got a rain check for a visit. We'll make it happen.
Thank you so much. It's been great being with you this morning.
Take care. Thank you again.